We can move on to the next talk, which is by Dr. Kollan Ganguly. Kollanda is already here, I hope, and he would be talking on hypocalcemia. If you can have Kollanda's slide, he's MD FRCP CCST. He's a senior consultant endocrinologist at Peerless Hospital and CK Birla Hospital, and he has had he's a regular speaker at various national and even international conferences, and is a fantastic speaker. So over to you, Kollanda, and really eager to hear you.
Okay, thank you, Demallo. I hope I don't get endocrine hypertension with my presentation. Let's see if it comes up nicely. Okay, I'm starting to share.
Yeah, just if you could
Is
make
it visible?
Full screen. Yeah, fine.
Full screen. Yeah.
Okay, fine. So approach to hypocalcemia. So you see, when first Anirmanda gave me this topic, I said, what do I read? How do I plan ahead with this talk? And actually, going through literature, I've learned quite a bit things about the hypocalcemia, because we take it for granted. Low calcium, just give calcium, that's it, finished. But there are a lot of other things there in hypocalcemia as well. But I'll try and keep it as basic and simple as we can, so that all of us can apply it in our day-to-day practice. So I'll just give you 3 hypothetical cases, so which you and me and everybody in this Zoom platform, delegates, would be dealing with day in, day out. So OPD basis, a 55-year-old person comes in, hypertensive, having aches and pain and weakness, and somebody sent a calcium level, it came back as 7. I've written corrected calcium is 7. What is your next step? Now, all the 3 cases, the calcium level is the same, but the approach will be different, which I'll tell you. The second case, same age, has come to your OPD. That person had neck surgery, some sort of neck surgery 2 months ago, and has a subacute onset of weakness, tingling in her hands, around the mouth. Corrected calcium is a 7. What is your next step? And the third, patient in intensive care having pneumonia, CO2 is going up, on the verge of ventilation now. Now corrected calcium is 7. What is the next step? So I think if you think of all the cases that you have in day-to-day practice, this will probably constitute more than 80% of your hypocalcemia patients. So I will go first to the definitions, to the mechanisms, and then I'll come last to the treatment bit. So hypocalcemia, if we want to keep it very simple, it is because the parathyroid hormone is the major player which keeps the calcium under control. The PTH works on the bones, works on the kidneys to increase the calcium absorption. Diet and skin makes vitamin D, which after going through liver forms 125 dihydroxyvitamin D, which is again helped by PTH. Both of these increase the gastrointestinal absorption of calcium. So basically, you will get hypocalcemia due to defect at any one of those points. So if you have low PTH secretion, that will cause an effect. If you have low gastrointestinal tract absorption, that will cause a defect. Low absorption from bone, that will cause a defect. So the definition, so calcium level is defined as a serum level of total calcium lower than 8.5 milligram. Now, this will be equivalent to 0.25 millimole. It's very important to write the millimoles, because most of the literature in Western world, they use, about many of the literatures, they use millimoles, and we use milligram per deciliter. So the normal range will be between 8.5 to 10.3, which will be 2.1 to 2.6 millimoles, or 4.4 to 5.2 milliequivalents per liter. So below 8.5 is hypocalcemia. Now, the lower range might vary a little bit as well. It's not written in gold that it can't vary. Calcium exists in 3 forms. Free form, which is the 50%, free or ionized calcium, that is 50%, calcium bound to anions, and calcium bound to albumin, plasma protein, which is 40%. So majority is free, 40% albumin, and rest complex ions. 80% of the protein bound is associated with albumin. Okay, so that's the physiology. So the automatic implication is, why don't we measure the ionized calcium and do everything based on ionized calcium alone? So I'll answer that later on. So because it is dependent on the albumin, you need to get the corrected calcium. So how to get the corrected calcium? Pretty simple. Measure the total calcium plus 0.8 into 4 minus serum albumin. So 4 is the normal level. So I'll give an example. So calcium is 7, albumin is 3.5. So corrected calcium is 7 plus 0.8 into 0.5. So that becomes 0.4. So this is 7.4. Now, there are a little bit of ifs and buts here as well, because this accuracy of this method is poor amongst critically ill patients. There, many of the most of the or some of the literature, if not most of them, do mention that we should be relying on ionized calcium to guide our treatment. But I will come to that in a little bit. Why? Because the binding of calcium to albumin is affected by extracellular fluid pH. And acidosis will decrease the calcium binding to protein and will increase the ionized calcium. So you might get false reading if you just use the corrected calcium that we normally do. Ionized calcium might be superior measurement in patients undergoing transfusions with saturated blood, in critical care units and late stages of CKD. But there are no factors which could be identified which will determine which particular group of patients you would estimate ionized calcium as opposed to our usual corrected calcium level. Now, when I asked my biochemistry colleagues that we don't ask for ionized calciums, the ionized calcium comes only with the ABG, or the acid-base arterial blood gas analysis, where sodium, potassium, and ionized calcium comes in it. And we ignore that. We don't see it. I don't see it. So the biochemist says that if you really want to get ionized calcium from the lab, you have to have simultaneously sodium, potassium done, because he gave me detailed explanation of electrodes and everything else. A lot of it went above my head. All in all, ionized calcium, just sending the lab value for ionized calcium doesn't seem to be cost effective, inverted commas, for the biochemistry department. Hence, most of the hospitals, almost all of the hospitals, don't have a routine ionized calcium as a check, but you can do it from the blood gas. But the blood gas electrolytes, I'm a little bit wary of them because they may not be giving you the exact figures. Blood gas should be, just PO2, PCO2, and the bicarbonate. That's what I look at, the blood gas, and the pH, of course. So the estimation of ionized calcium is a little bit cloudy as to the importance of it and whether we should routinely be using it. Even if we want it, we can't because of cost-effective problems. So what are the symptoms or the signs of hypocalcemia? So why does it occur? The irritability occurs because of changes in action potential, because a nerve signal is propagated through the opening of the voltage-gated sodium channels. This causes membrane depolarization. So if you have less calcium, this opens up and the nerves become irritable because the threshold for the activation of these sodium channels is lowered. That makes the nerves very excitable. So we know about the Chopsticks, tissues, and the herb signs. They are a manifestation of this hyper-irritability. Now, this is from the Oxford textbook of endocrinology. These are the clinical features of hypocalcemia. The paresthesia of the fingertips, toes, and circummolar regions. I think most of the patients do have it actually, if they have significant hypocalcemia. Tetany, carpopedal spasm, and muscle cramps. Less proportion of patients get it, but more severe the hypocalcemia. I will tell you a little bit about the Chopstick sign and the Trousseau sign. You get prolonged QT interval on the ECG, and I'll tell you a little bit about it. So that's the Chopstick sign, but it is not very specific because about 10% of normal individuals might have it. So how to elicit it. You just tap just below the zygomatic arch and the corner of the mouth. So you'll get a positive response in the form of twitching of the lip at the corner of the mouth and spasm of all the facial muscles. So this is Jobstech sign, but it is present in 10% of normal individuals and a small proportion of patients of hypocalcemia. But this is more is rather commoner in hypocalcemia. So how to elicit the Trousseau sign? Herein, you inflate the blood pressure cuff to 20 millimeters above the systolic blood pressure for 3 minutes. So if the systolic blood pressure comes as 130, you make it 150, stay at 150 for 3 minutes, then observe this. Now, this can occur between 30 to 50% of patients with the marked hypocalcemia. And I could get this out from one of the journals, which is very interesting and makes you feel good as a doctor. Well, that's the patient's perspective. I was really surprised my hand while taking my blood pressure and leg contracture. My symptoms improved rapidly after they started treatment. I can recall distinctly 1 or 2 cases where the nurses had mentioned that while taking the blood pressure, the patient's hand began to twitch and the patients complained of pain whenever they took the blood pressure, and it came, and on investigation it came out that they did have hypocalcemia. Similarly, 1 or 2 patients, just based on the ECG, a hypocalcemia could be diagnosed. So I think we should keep our antennas up for these sort of subtle signs and symptoms. So talking about ECG, this is the QT interval. So how do you measure it? You make a straight line through the downslope of the T wave, and where it cuts it, the distance from there to the beginning of the R wave is QT, and you correct it. All the machines which measure the ECG corrects it for you, so you don't have to use any formula. So if there's a small U wave, ignore it. If there's a larger V wave merging with the T, include it, and that's your QT interval. So the QT is prolonged if it is more than 440, and if it's more than 500, that will increase the risk of torsades and ventricular tachycardia. But that is very unusual to have, but QT prolongation might be there in hypocalcemia. So a useful rule of thumb is that a normal QT is less than half the preceding RR interval. So if I show you these, so hypocalcemia, what does it cause? It causes, so here is hypercalcemia, this is normal, this is hypo. You can clearly see the prolongation of the QTC. Typically, the T wave is left unchanged. In extreme cases, you may get ST changes simulating MI, but overall, this is more specific for hypocalcemia. So this is the typical ECG. So the QT is more than the half of the RR, preceding RR. That's a rough guide. So in hospitalized patients, sepsis is a well-recognized risk factor, but we don't know exactly why, because in more than 50% of patients, there was no identifiable etiology. Although the hypocalcemia in intensive care has been linked with mortality and morbidity, mainly cardiac, there have not been any RCTs to examine the effects of calcium treatment on mortality. So we do not know really that in intensive care patients, giving calcium, does it improve mortality or not? But it makes common sense that to correct it, but also common sense not to overcorrect it, not to overdo it. So the mechanisms are multiple. In critical ill patients, remember I gave you a case, the third case was a critical ill patient in ITU. So you have got due to PTH problems, suppressing of the PTH, due to vitamin D deficiency, due to hyperphosphatemia, due to tumor lysis syndrome, due to pancreatitis, and due to alkalosis, a lot of, and drugs used in critical care unit, a lot of reasons why the calcium might go down, particularly more so in patients who are already vitamin D deficient. Now you can see here, the common causes are vitamin D deficiency, hypoparathyroidism as a result of surgery, and less common is vitamin D resistance. But I think, although they have put it as a rare, this is, I don't think this is rare. I think this is slowly becoming commoner. Hypomagnesemia. So little bit more light on hypomagnesemia. Is that a problem? It is a problem. Why? So this is the normal range of magnesium. The prevalence of hypermagnesemia in various studies ranges from 13 to 47% in type 2. And I'll show you one data from India where they assessed the incidence of hypomagnesemia amongst non-critically ill admitted patients with type 2 diabetes. And what they found that patients with type 2 diabetes who were admitted, about 11% had hypomagnesemia. So it is by no means uncommon. I would say it is common. And they found that it was commoner in patients who had poor glycemic control. So the magnesium might cause hypocalcemia by interfering with PTH action and by suppressing PTH as well. What are the drugs, the multiple drugs which may cause it? Cisplatin, diuretics, aminoglycosides, amphotericin. You have got anti-epileptics which might cause it, rifampicin. Very important, LoopDirectrix, commonly used in intensive care. They might cause it. You might have proton pump inhibitors and glucocorticoids. All of them routine use in intensive care and otherwise as well, LoopDirectrix and PPIs. So LoopDirectrix, how do they do it? Because the calcium is reabsorbed primarily in a passive mode, depending on the gradient created by the sodium transport. So if that is inhibited, the calcium absorption is automatically inhibited, and therefore you get hypocalcemia. Also, the LoopDirectrix cause hypomagnesemia, and that itself can cause hypocalcemia. The PPI, it reduces the acidic environment. That may reduce the calcium absorption in some studies up to 80%. Now, the Omeprazole study, one study had shown that it not only inhibits the gastric hydrogen potassium ATPase, but in the osteoclasts also it may prevent the vacuolar type hydrogen ATPase, and that might prevent calcium absorption. And the PPIs may also cause magnesium drop. That might also cause problems with calcium level. So if you have got somebody with low calcium, what's the algorithm? So just like for anemia, our first step is to check MCV. When MCV is low for iron and MCV is more B12 and normal, then if you look for chronic disease, just like that. For calcium, first step, PTH. If the PTH is high, then look for creatinine. Normal, look for vitamin D. That is low, clear, vitamin D deficiency. If the creatinine is high, oh, so that's renal failure causing it. If the PTH is low or normal, oh, magnesium might be the problem. Check magnesium. If the magnesium is normal, everything else is normal, then we are looking at rarer causes. But most of the causes would be stuck in here, here, and here. So 9.5 times out of 10, you will get your answer somewhere here. So treatment bit. Now, let me tell you first, I've gone through various textbooks in endocrinology and various articles. There's not, I won't say that there is much concordance. There's a little bit of variation regarding the exact treatment. There are no RCTs, proper RCTs to guide us. So this is based on the Williams textbook and the Oxford textbook and one article from intensive care, which I have told you about the treatment. So before the treatment, what would you treat with? So I've just brought this out, the various compositions of the various calcium preparations that we have. One of the commonest ones is calcium gluconate that we have. I have put it up purposely so we know that the 10% bit that we have in our ward, it comes as a 10 ml vial, so it's about 93 milligrams. So roughly, one vial is equal to 100 milligrams, roughly. So this we should remember in the background. So that will depend, because from what I'm going to tell next, this is important. So intravenous calcium solutions are hyperosmolar. It should be administered to a large vein. Now, this is important because I've seen prescriptions of 1 ampule calcium gluconate IV TDS. So the nurses will just give it as a shot. rapid administration may result in cardiac arrhythmia. So IV calcium should be monitored properly. You should give it in a big vein. You should probably use calcium gluconate if you're giving it peripherally because it has lower osmolarity. So you give it over 10 minutes, 10 minutes. So hypocalcemia, you want to give it an IV calcium gluconate, you give it over 10 minutes. So how much? 1 to 2 milligrams per elemental calcium per kilogram. How much does it amount to? So that is 1 ampule in 50 ml NS or 5% dextrose over 10 minutes, because 1 ampule is, as I told you, roughly about 100 milligrams. And if I put 1.5 milligram elemental calcium per kilogram for a 70 kilogram person, it will be roughly around 100 milligram. So first step, hypocalcemia, you want to treat it IV. When to give IV? If the patient is symptomatic, in critical care, less than 8%, 8 milligram per DL. So 1 ampule in 50 ml NS of 5% dextrose over 10 minutes. Then the calcium will go up and come down again. So you need to give an infusion. What sort of infusion? I will show in this slide and the next as well. So a bolus dose of calcium should be followed by continuous infusion. How? So you need to give about this much, 0.5 to 1.5 per kg per hour. Don't worry, I will just make it simple. For a 70 kilogram person, half to 1 ampule per hour. I'll show it in the next slide. The individual responses vary a lot from those who have treated calcium. You will find some people just with 1 or 2 ampoules, it just comes up to normal. Some need enormous amounts of calcium to get corrected, particularly after the post-parathyroid resection. So this is from the Oxford textbook, which has got the best one, I think, as far as practical thyroid and calcium usage in treating hypocalcemia. So here you have given the bolus dose, which is 1 ampule in 50 ml NS or 5% dextrose over half an hour. You are given that. I've shown you that's in the background here. Over 10 minutes, you have given that. Now a maintenance dose. So 10 ampules in 1 liter of 5% dextrose or 0.9 NS. You don't have 1 liter bag, you have 500 ml bag, then use 5 ampules. You start at the initial dose rate of 50 ml per hour. You start at 50 ml per hour, stop at 6 hours and check. So this 50 ml per hour of this concentration of calcium will raise your calcium by 1.2 to 2 milligram in 6 hours. Okay. So if you have a 500 ml bag in your hospital, 5 ampules in 500 ml NS or 5% dextrose, 50 ml per hour. After 6 hours, stop and check calcium. Corrected, no need, not corrected, continue further. So chronic hypocalcemia, for milder degrees of hypocalcemia, and there is clear vitamin D deficiency, we know the treatment 60,000 units once weekly for 8 weeks, then monthly. And most available vitamin D preparations, because the vitamin D 60,000 units that you give, it may start to kick in after a few days, but the commonly calcium tablets that we get, they are joint, they are available as a fixed dose with calcium 500 milligram and vitamin D 500 units. You may start that initially at least. If you have neck surgery and you find out that they had a thyroidectomy done and parathyroid was inadvertently taken out, that's quite common. You get these sort of vitamin D will not be effective. For those patients, you need calcitriol. You start with 0.5 micrograms per day and increase it every 4 to 7 days till you get the calcium in the lower reference range. So if I put it in an algorithm like this, low calcium, so this is less than, I think it will come down to just under 8. If you want to acutely correct it, IV calcium, which I've told you, it is chronic, then you give vitamin D treatment. If there is no parathyroid hormone or low parathyroid hormone, you give analog in the form of calcitriol. If the parathyroid hormone is intact, you give vitamin D as 60,000 units weekly. 50,000 is not available in India, 60,000 is. So I've given you the cases. That's my last slide. So this patient has come to the OPD. You check the PTH that had come back as raised. Vitamin D was low, so you give vitamin D weekly for 8 weeks, but the calcium level is quite low. So I would normally give a calcium 500 milligram tablet twice a week. It will come with combination of vitamin D. Doesn't matter. You give it for 1 week, check calcium after 1 week. It would have come up nicely. By that time, the vitamin D loading dose which I have given will begin to kick in. The second case, neck surgery. So almost always it is that this patient has hypoparathyroidism, and that has they have chopped off her parathyroid glands. So what would you do here? You start calcitriol 0.5 microgram per day, check after 4 to 7 days, and then adjust accordingly. You may also start calcium at least for the first 2 or 3 days, so that it will give time for the calcitriol to kick in. And for the ITU patient, you give 1 ampule over 10 minutes, and then 5 ampules in 500 ml NS, start at 50 ml per hour, check after 6 hours, and then proceed. So with that, I end. 3 seconds left. Thank you.
Thank you, Kolanda, for an excellent talk. Just a couple of questions which have come up is one is, in patients who the commonest scenario which we face in our day-to-day practice is, is patients who have thyroid surgery, planned thyroid surgery. In those patients, how do we preempt or prevent development of hypocalcemia? Any suggestion do you have, especially how to monitor and when to monitor after the surgery?
So if it is thyroid surgery you're talking about, so any thyroid surgery, whether it's for malignancy or just for cosmetic reason or for pressure, offloading pressure symptoms, I always check their calcium and vitamin D first. So I check 3 things: calcium, vitamin D, and PTH first. If they're vitamin D deficient to begin with, I start the vitamin D at least 2 weeks before their surgery, so that they are vitamin D replete at the time of going into surgery. Post-surgery, I check their calcium levels at 1 hour and 6 hours, and then every day while they are in hospital. So I can catch the hypocalcemia if it occurs early. Because if you don't do that, on a few occasions, patient will be discharged and they will be readmitted just because of the hypocalcemia. It has to be, you're absolutely right. It has to be, there has to be a preventative step to prevent this from happening.
And the second part is, patients having hyperparathyroidism with hypercalcemia undergoing surgery. So, a lot of times, they land up in hypocalcemia post-operatively. Most importantly, if they are vitamin D deficient pre-operatively, also we can have the problem, especially with regards to hypocalcemia. Your opinion and
suggestion. Yes. So I think that's a dilemma, isn't it? So hyperparathyroidism and vitamin D deficiency, they have hypercalcemia. Do you correct the vitamin D or not? So the answer is you correct the vitamin D. So in these cases, I don't give loading dose of 60,000. I give the daily dose of 2,000 per day with monitoring of the calcium. Because if you correct the vitamin D, maybe the PTH will also come down to a significant extent without increasing the calcium. But because you're giving 2,000 units per day and you're checking the calcium after 5 to 7 days, you can stop it if you realize that the calcium is going up. So the answer is you give vitamin D pre-op if they are vitamin D deficient. Because if you don't do that, you will land in trouble post-op. So after operation, again, I check the calcium levels immediately post-op, and then after 6 hours, and then every day, so that I can catch the hypocalcemia and start accordingly. And almost 10 out of 10, they will be discharged on calcitriol 0.5 to 1 microgram per day at the point of discharge. If that is not done, which is not done many cases in small surgical units, and they land up in terrible hypocalcemia. And as you very well know, those people who have had all their parathyroid glands removed, it is a nightmare sometimes trying to control their hypocalcemia.
Thank you for an excellent talk and very practical tips which are very important for us in our day-to-day care. Thank you, Kolanda. So Jejeta has been waiting patiently.